Good morning, everyone. Thank you for joining us for our virtual coffee break today. As thousands and thousands of Wisconsinites are getting ready for the Wisconsin gun deer season that opens up on Saturday, we thought it would be a really great time to focus in on eye health. It's something, obviously, if you're a hunter or anyone in our community, is very important moving into the future. So we're really honored today to have Dr. Murray Brilliant joining us as a speaker. He's a PhD and retired senior research scientist with more than 30 years of experience in genetic research with a specialty in albinism and complex trait genetics. He held the James Weber Endowed Chair at the Marshfield Clinic Research Institute, where he directed the Center for Human Genetics, the Center for Precision Medicine Research, and the Personalized Medicine Research Project. Before his retirement, congratulations, by the way, Dr. Brilliant led the All of Us Wisconsin Research Project, and his research has helped map the mouse and human genomes, uncovered several genes, and led to insights into a variety of diseases, including albinism, epilepsy, cleft palate, Fragile X syndrome, and vision disorders such as glaucoma and age-related macular degeneration. He pioneered efforts to improve patient care, focusing on avoiding adverse drug reactions and novel treatments for eye disorders. So as you can tell, he has a lot of knowledge in a lot of different areas, and we're really looking forward to hearing a little bit more about age-related macular degeneration and what you've learned over the years. So thank you for joining us today.
It's my pleasure to join you and to share some of the information that we've gotten from our research in age-related macular degeneration. And if you'll bear with me, I'm going to show my slides here, if I can. Hold on. Oh, right, and there. Hopefully you can see the slides. So today I'll talk about age-related macular degeneration, or AMD for short. And it's a very common disorder. It affects 1 out of 3 elderly individuals in the US and also in the other parts of the world. In its early forms, AMD causes troubling visual disturbance, and it's more of the your central vision that gets affected. And in its advanced forms, it results in functional blindness. And this is a tragedy because as people age, aging is hard enough, take it from me, but doing this with functional blindness would be very, very difficult. It's estimated that more than 9 million people have intermediate or advanced AMD in the US, and about 30 to 50 million people worldwide. So this is a very common disorder. So as I mentioned, it's a leading cause of irreversible blindness among adults 65 years or older in the Western world. And if you see here, this is a cutaway of a picture of a cutaway of an eye. We haven't cut away a real eye here, but in the back of the eye, so toward the right, there is the facing outside. And you can see the lens and the cornea and that sort of thing in the front of the eye. And in the back of the eye, there's an area which gives us our best vision called the macula. And within the macula, there's even a specialized part called the fovea, which is kind of a little bit of a dimple in the back of the eye. And that's our best vision. That is, if you're doing fine work or reading or something that you're really looking at with the center of your vision, that's where our most acute vision is. And that is the area that, that gets disturbed and diseased in age-related macular degeneration. So using a large population studies, we've been able to determine which genes are associated with AMD. We do this by comparing people with AMD versus people who don't have AMD, and then looking for a genetic variation between those two classes. And if we look at a large enough number of people, we get the pattern that's shown in the graph below. We call that a Manhattan plot because obviously it looks like the skyline of Manhattan. And each of those peaks corresponds to a different gene that's associated with risk for age-related macular degeneration. And putting this all together, we can actually come up with a formula to determine and predict who is most likely to develop age-related macular degeneration. So it's one thing to know what your risk is for age-related macular degeneration, but that's not really worth knowing unless we can do something about it. So we've been trying to figure out if we already might have a preventative treatment for age-related macular degeneration. And in a variety of studies by my group and others, we've identified genes for albinism. Albinism, that's the term for people who are albino, people who lack pigment. And one of the interesting features of albinism is that they have very poor vision, and that poor vision results in lack of development of the retina in the area that's also affected by age-related macular degeneration. And using the information that we've gained from studying diseases such as albinism, we've identified a chemical called Dopa or Ldopa as being protective for AMD. So in looking at this, we want to know if Dopa, which is a signal to other cells, if Dopa signaling is protective for AMD, then people with higher amounts of Dopa should be resistant to AMD. And it turns out that Dopa is one of the precursors for making melanin, for making pigment. And that's the connection with albinism. People with albinism don't make Dopa in their retina. But people who have darker pigmentation make a lot of Dopa in their retina. So we could compare people of color versus people who are lightly pigmented to see, do they get less AMD, for example, and also people who are receiving Ldopa as a therapy for Parkinson's or restless legs, which is one of the disorders that Ldopa is given for, if those people have less age-related macular degeneration. And so if we look at the incidence here, who gets age-related macular degeneration? In this chart, you can see that as we get older, which is the age groups are at the bottom of this graph. So for example, as we get all the way out to age 80 and more, you see a really strong peak in the incidence of AMD. And that strong peak is largely confined to people who have less pigment, that is Caucasians, white people. And we don't see very much age-related macular degeneration in other ethnic groups where there is considerable pigment. That is in African Americans or Black people or intermediate people of intermediate pigmentation, such as Hispanic group. So age-related macular degeneration is largely a disorder that affects white people. And that also then tends to tell us that pigment and Ldopa might be protective against age-related macular degeneration. So what about people, especially Caucasians, for example, that we give Ldopa to? And do they get more or less age-related macular degeneration? So looking at large numbers of patients and their medical records, we can look at this. So we've already been doing a clinical trial on the effect of Ldopa on age-related macular degeneration for over 40 years now. And that is, again, people are given Ldopa for Parkinson's and also for restless legs. So these individuals take Ldopa to treat their movement disorders, sometimes even as much as 1 gram per day. So the question is, do people on Ldopa develop age-related macular degeneration? So we selected a group of 37,000 people, 314 of which were given Ldopa, that prescription, around the age of 67, and almost 1,800 of these people developed age-related macular degeneration around age 71. So you see, we generally give Ldopa at 4 years earlier than we diagnose age-related macular degeneration. And we had 59 people with both in their clinical records. So among those 59 people, we should see more of the prescriptions before the diagnosis of AMD, because 67 is earlier age than 71. So typically, we looked at most people, as you see at the top, most people would be diagnosed for age-related macular degeneration about 4 years 4 years after most people would be given Ldopa. So if this is a random thing, we should see more people getting Ldopa before their AMD diagnosis. But that's not what we see. We see the opposite pattern. So in most cases, we see the opposite pattern, that there's a diagnosis of age-related macular degeneration before the prescription for Ldopa. And so that tells us that Ldopa this is behaving in exactly the opposite of what we would have expected if the two were unrelated. But since we do see more of the diagnosis of AMD before they get Ldopa, that means that people who are getting Ldopa are protected from AMD. So the current AMD treatment options are pretty bad. There are two major forms of age-related macular degeneration. One is called dry and the other is called wet AMD. So for dry AMD, which is approximately 90% of people with AMD, we don't really have much to offer. There's some vitamin supplements that have been shown to delay the onset and progression of AMD, but that's pretty much all we have. For wet AMD, which it degenerates the retina to the point where you have growth of blood vessels and bleeding in the back of the eye, we only have one therapy, which is an antibody that is against something called VEGF. So this anti-VEGF antibody is a standard treatment. And what happens is, in order to get that to the retina, they actually inject this into the eyeball. And this is a very intrusive, uncomfortable, and expensive thing to do. In fact, in terms of Medicare Part B spending, this is costing us $3.5 billion in 2017 alone. So so the treatment for the 10% of AMD that's devastating, this wet AMD, costs a small fortune here. And it's terrible for the patients that have to get these injections into their eyeball once a month or once every other month, something like that. So, the point here is that in looking at large populations, we have a potential therapy, Ldopa, which is a drug that's been around for a long time. It's relatively safe, especially at the doses that are needed for protecting us against AMD. It's relatively safe, and it's extremely cheap. It's a generic drug, again, that's been around, it's safe, seems to be in preliminary studies, and there have been some preliminary trials for looking at the effect of Ldopa on people with AMD. It looks very, very promising. So by looking at large numbers of people, we can actually come up with novel therapies that might really address these types of disorders and save people here, in this case, from blindness. So this is part of an initiative or an example of what we can do under the NIH Precision Medicine Initiative. And this is that it's a way to look at large numbers of people that take into account variability of genes, environment, and lifestyle, and that can not only predict, but also come up with ways to treat common medical disorders like AMD. The Precision Medicine Initiative has led to something called the NIH All of Us research program that I was privileged to be part of. This is a picture of me with the director of the NIH, Francis Collins. And if you can imagine that, what we were able to do with 37,000 people and come up with a way to treat millions of people or prevent millions of people from blindness in their old age, what we could come up with the million people that the All of Us research program envisions recruiting. So I think the future is very bright because programs like the All of Us research program will help us to, in many ways, to increase wellness and resilience, promote healthy living, reduce health disparities, develop a risk assessment, as we've done with age-related macular degeneration, and most importantly, prevention strategies to preempt this type of disease, to provide earlier and more accurate diagnoses, and to decrease the illness burden, and to improve health outcomes and reduce disease impact through improved treatment and development of precision interventions. So I'm very pleased that I was part of the many different studies, and that especially with the All of Us program. And I think that this offers amazing possibilities for the future of healthcare. So, and I want to thank you all for your attention.
Thank you so much again, Dr. Brilliant. I just think this is such an applicable topic to discuss, and it really highlights the potential of precision medicine. Like you said, looking at very commonly occurring types of diseases and disorders. I think a lot of times when folks hear about genetics and research, they think about those really rare diseases, which are extremely important as well. But looking at things that we've just kind of taken for granted as maybe part of the aging process or different things, that affect a large number of people. There's so much potential there. So very grateful we have scientists like yourself who are looking into this. We are going to have kind of question and answer. If anyone out there has any very specific questions, you can leave those in the comments, and we'll do our best to get those answers back to you as quickly as possible. I would be curious, Dr. Brilliant, if you have any advice, if someone's watching this video and they kind of fall into that category at being a higher risk for age-related macular degeneration, is there something they could do today or a conversation they could have with their care provider? Do you have any kind of take-home knowledge for folks on how to apply this?
So thanks for bringing that up. We don't have approval yet for Ldopa to treat age-related macular degeneration. This is pending the results of several clinical trials. But I think that the future is bright, that the preliminary data coming out of these clinical trials is very, it seems to be very good. And so I think in the next few years, we will be able to more widely have this available to people who are suffering from age-related macular degeneration or people who are at risk for that. So currently, Ldopa is not yet approved for treating age-related macular degeneration, but this is really an incredible first step in the sort of the pathway to prevent a major disease like this.
Mhm. Absolutely. Well, thank you. And thank you again for being with us this morning. Hopefully we can reconnect again for some more virtual events in the future.
Sure.
Have a great day, everyone. Bye-bye.
Bye.